All right, I'm Emily Speer from Denver, Colorado, and thanks so much to SAGES and the panel for the opportunity to talk about the role of manometry and endoflip in preoperative workup. So I have no disclosures today, including with the manufacturers of the technologies I'll be talking about today. Seems like about 7. So today we'll delve into the tools we have available for the preoperative workup of esophageal motility disorders, focusing on manometry and endoflip, which is also known as impedance planimetry. And both of these technologies play a key role in diagnosing and characterizing esophageal abnormalities and really getting into that physiology so that we can guide surgical interventions for better patient outcomes. These are respective pictures of what the equipment and catheters and report images look like. On the left, you can see the manometry tower, what the catheter looks like, what the tracings look like, and then on the right, you can see the endoflip tower, which is pretty similar. The catheter is a balloon, which we'll talk about in a second, and this is what the tracings look like. Manometry is done transnasally, and it can be done awake in the office. It's 36 sensors, and it measures primary peristalsis, which is the peristalsis after you swallow, and the interpretations are done afterwards. And compared to endoflip, this is usually done transorally, sedated in the GI lab or in the OR, and it's a balloon catheter with 16 sensors that's used to measure secondary peristalsis. So you inflate the balloon, and then that triggers esophageal distension, which then triggers the secondary peristalsis. And these data can be appreciated in real time. So how is manometry useful? Manometry is still the gold standard in the preoperative assessment of esophageal motility, so that physiology. It helps rule out EGJ outflow as well as disorders of peristalsis using the Chicago version 4.0 manometry classification system. And it can help tease out motility disorders that can mimic GERD like achalasia and aperistalsis. And manometry is essential for obtaining a complete picture of the patient's individual esophagogastric physiology so we can tailor our surgical procedures. And it's considered mandatory prior to anti-reflux surgery by several respected organizations with some exceptions. It's also part of a comprehensive Foregut center. So aside from its obvious medical decision making benefits, having these high quality, readily available studies are essential for patient throughput in your practice. And it's a source of referrals because in many parts of the country, this service is not readily available. So when people find out you're doing it, they will send patients your way. But there are some significant downsides to manometry that are really unavoidable at this point, and so kind of try to find the next best thing. Often, immediate reimbursement for manometry is not commensurate with the substantial time, expertise, and resource investment that goes into them. So aside from training your staff, which can take a lot of time, when you take into account the preparation, probe placement, data interpretation, formal reads, uploading the reads, catheter care, maintenance. These studies, each one can take about an hour to an hour and a half, which is similar to the actual Foregut operations that we do. And then there are also administrative challenges with doing these procedures in clinic. And then also, due to the complexity and ever-changing understanding of esophageal physiology, performing and analyzing and interpreting these tests requires training and expertise. And we're now on Chicago version 4.0, but some motility softwares aren't even up to date on this, which then can make interpretations even more difficult. And then finally, it's an invasive procedure. It requires inserting a catheter into the esophagus, which is uncomfortable. It causes gagging in most patients. Some people don't tolerate it at all. And then there are rare complications, perforation, bleeding, aspiration, which again are rare, but they can happen. And then for all these reasons just listed, there aren't a lot of physicians other than us Foregut and bariatric surgeons who are dying to offer this service. And admin often doesn't see us doing these tests as a big financial satisfier to them either. So we really do it because it's the right thing for our patients and for their workup. So enter endoflip. It has excellent correlation with certain motility diagnoses, and it can actually help expedite your workup. So with the advent of flip panometry, we can start to measure a sort of surrogate of esophageal motility as shown in these images. Manometry is on the top and the corresponding flip panometry images are on the bottom here. And it's also proving to be pretty reliable in the primary diagnosis of normal motility or EGJ outflow disorders. So there are a number of studies that show that when endoflip shows either normal motility or disorders of EGJ outflow, this marries up with manometry findings very well, and theoretically, manometry could even be avoided in these patients altogether. And this was a study done out of Northwestern. They looked at 722 patients who underwent both flip panometry as well as manometry to try to classify esophageal motility disorders using flip. And each of these pie charts represents the flip panometry motility classification with the proportions of conclusive Chicago 4.0 manometry diagnoses, and the data labels are the number of patients. So you can see here that of the patients with normal flip, 87% had normal manometry, and of the patients with esophageal outflow obstruction of some sort on panometry, 92% had either achalasia or EGJOO on manometry. And in fact, as this technology evolves, its use for identifying disorders of EGJ outflow may someday surpass manometry. You can see it's currently a part of Chicago 4.0 algorithm. And then in just one study that was comparing the two, endoflip actually picked up some patients that weren't picked up by manometry who symptomatically improved after treatment for achalasia or EGJ outflow obstruction. So really, as you can see from the last slides, there's good evidence that endoflip done at initial endoscopy could actually preclude the need for uncomfortable manometry by excluding some of those primary motility disorders. And then because you get real-time feedback, you can even theoretically treat them in the same setting. And some surgeons are performing endoflip on the operating table with IV sedation anesthesia to help guide their operative plan. And some groups have come up with algorithms for endoflip to actually replace manometry in certain circumstances, certainly not all, but this is one published by Mike Ujiki's group, the North Shore group, where when and where they use endoflip in lieu of manometry. So while endoflip is valuable for assessing certain esophageal motility diagnoses, there are still some very real limitations. It's widely considered by the AGA and even Medtronic, the makers of endoflip themselves, that it's still considered complementary to manometry. And because it's newer, we still need more robust studies, and it's not definitive yet. It can't fully replace manometry at this time. And then unlike manometry, there are still a lot of variables in the literature and the data that need to be more standardized. So things that can affect motility and your endoflip outcomes are things like sedation, pneumoperitoneum, patient positioning, balloon fill volume. And then reimbursement, although it's not bundled, it does take extra time, and like manometry, reimbursement can be variable. And then availability can be limited, obviously, in certain healthcare settings due to it being yet another added equipment cost on top of manometry, as well as it requiring expertise. So in short, manometry and endoflip have complementary roles in the preoperative workup of esophageal motility. And while manometry is still the gold standard, endoflip certainly has an increasing role, but it can't yet replace manometry. Utilizing these modalities based on patient-specific factors can enhance diagnostic accuracy and ultimately improve surgical outcomes for our patients. Thank you.